Hello and welcome to week 2, chapter 3 of an introduction to community and public health. This week we're going to be talking about epidemiology, which is the study of disease, injury, and death in the community. The objectives for this week include being able to define the terms epidemic, endemic, pandemic, epidemiology, and epidemiologist, and explain their importance in community and public health. You should be able to list some diseases that cause epidemics in the past and some that are causing epidemics today. That should be easy given our current environment. Discuss how the practice of epidemiology has changed since the days of Benjamin Rush and John Snow. Explain why rates are important in epidemiology and list some of the commonly used rates. So we'll discuss rates in detail. Define incidence and prevalence rates and provide examples of each. Discuss the importance of disease reporting to a community's health and describe the reporting process. Define the following standardized measures of health status. So these include life expectancy, years of potential life lost, which is abbreviated YPLL, disability adjusted life years, abbreviated DALYs, and health adjusted life expectancy, abbreviated HALE. You'll identify sources of secondary data used by epidemiologists, community health workers, and health officials, and list the types of data available from each source. You'll describe the two main types of epidemiological studies. And finally, you should be able to list the criteria used to evaluate whether or not a risk factor causes a disease. So to start, let's go over a few of the important terms when thinking about epidemiology. So the first is that epidemiology is defined as population medicine. It's the study of the distribution and determinants of health-related states or events in specified populations. An epidemiologist is one who practices epidemiology, so they're concerned with the course of disease in a population. They collect information about disease status of a community. They want to know things like how many people are sick, who is sick, when did they become sick, where do they live, and they use this data to prevent disease outbreaks or determine effectiveness of prevention efforts. An epidemic is an unexpectedly large number of cases of an illness, specific health-related behavior, or event in a particular population. An endemic disease is one that occurs regularly in a population as a matter of course. So the flu, the annual flu, can be considered an endemic. It's a disease that occurs regularly, so oftentimes during the winter months within a population on an annual basis. And then a pandemic is an outbreak of disease over a wide geographic area, such as a continent, or as we're currently experiencing, the globe. We're going to take a minute to talk about the history of epidemiology because just like the history of public health, understanding the history of epidemiology is important in understanding the importance of epidemiology today. Excuse me for a minute, I've got a little error in my recording. Okay, so we're going to talk about the history of epidemiology. The concept of epidemiology dates back to Hippocrates around 300 BCs. He suggested a relationship between the occurrence of disease and the physical environment. So an example would be a disease fitting the description of malaria were found to occur in the vicinity of marshes and swamps. And Hippocrates noticed that there was some sort of causation causing this disease because of the environment. After the fall of classical civilizations of Greece and Rome, few advances were made, and we saw subsequent waves of infectious disease epidemics like the plague, yellow fever, Black Death, cholera, etc. An example of how epidemiological methods can be used to limit disease and deaths is the example of John Snow. So John Snow was a prominent physician who investigated the outbreak of yellow fever in London. He interviewed numerous victims and their families and concluded that the source of the epidemic was probably water drawn from a particular communal well located on Broad Street. Snow stopped the epidemic in 1854 when he removed the pump handle from the Broad Street pump, meaning people had to obtain their water elsewhere. This is a classic example of how epidemiological methods can be used to limit disease and death. Rates are really important in understanding epidemiology and really important to epidemiologists, as they allow for comparison of outbreaks at different times or in different places. And you'll want to be familiar with all of these terms and all of these rates in order to speak fluently about epidemiology. Cases include people afflicted, so those who are currently sick. And rates are the number of events in a given population over a given period of time or a given point in time. So natality is a birth rate, how many births occur maybe in a given year or on a given day. Morbidity is the rate of illness in a population. And mortality or fatality, death rates, are the number of deaths in a population divided by the total population. So if we wanted to figure out the fatality rates for a population in a given year, we would take that number and divide it by the total population in that given year. A population at risk are people in the population who are susceptible to a particular disease or condition. And when we think about bacterial or viral infections, this could be the general population. When we think about lifestyle diseases, it could be people who have specific risk factors. Other rates that you should be familiar with are the incidence, prevalence, and attack rates. An incident rate is the number of new health-related events or cases of disease divided by population at risk. This can be important in the study of acute diseases. These are the diseases in which the peak severity of symptoms occurs and subsides within days or weeks, meaning short-term diseases. Attack rates are the incidence rate calculated for a particular population for a single disease outbreak, and it's usually expressed as a percentage. Prevalence rate is the number of new and old cases in a given period of time, divided by the total number in that population. So this is really useful in the study of chronic diseases, like those that last 3 months or longer. So in order to get a better visual of incident prevalence and attack rates, you can look at table 3.3 in your text. Again, the incidence rate is the number of new health-related events or causes of a disease over the number of people exposed to risk during this period. An attack rate is the cumulative incidence of infection in a group observed during an epidemic, divided by the number of people exposed and then multiplied by 100. Again, that's typically written in a percentage. And our prevalence rate is the total number of all individuals who have an attribute or disease at a certain point in time over the population at risk of having the attribute or disease at this point or period in time. So when we think about how we interpret these rates, incidence and prevalence rates are expressed as crude or specific. So crude rate is a rate in which the denominator includes the total population. An age-adjusted rate is used to make comparisons of relative risk across groups and over time when groups differ in age structure. So for example, an appropriate age-adjusted rate would be the mortality rates of motor vehicle accidents in people aged 20 to 30. You would only use the population of age 20 to 30 as your total population, and the number of people who died in a motor vehicle accident over a specific period of time over that total population just of 20 to 30-year-old people. Physicians, clinics, and hospitals are required to report births, deaths, and notifiable diseases. These include things like infectious diseases for which health officials request or require reporting, and they can become epidemics. So when we think about COVID, it is the responsibility of a physician, a clinic, a hospital, public health to report COVID cases so that public health can help track and slow the spread. They're reported to the CDC, the Center for Disease Control, via the National Electronic Telecommunication System, which is abbreviated NETS, N-E-T-S. And as you can imagine, there are various challenges to maintaining accurate data. As we've experienced with COVID, if somebody is tested once and then has another positive test, a follow-up test, it could be that their case was reported twice. Or it could be that somebody is positive, has all of the symptoms, but chooses not to get tested. Therefore, their result is not, their positive test is not put into the system. So the table that you're looking at here is the notifiable disease scheme. When doctors, a clinic, or hospitals are aware of an infectious disease for which health officials request or require reporting for public health reasons, they then report to their local health department. The local health department sends that data to the state health department, who sends that data to the Center for Disease Control and Prevention, or the CDC. Typically, this occurs in monthly summaries and annual reports from the State Department back to the local health department, and from the CDC back to the state health department. Those occur in weekly summary reports. Now, this can be altered, as we've seen. Instance, our state health department is on a daily basis updating COVID cases per county because they're tracking the spread of the pandemic very closely. The information that's included in these reports are usually morbidity and mortality weekly reports, so how many people have died from and how many people have tested positive or have the disease. It's important to understand that all of the scheme and this whole process requires lots of lab support. People have to be educated in health. There's usually case investigation that occurs, laboratory confirmations, special reagents in order to ensure that you have the chemicals needed to test for the disease, and expertise. So it's a complex system requiring a lot of working parts. So the standardized measurements of health status of populations include mortality statistics, which are the most reliable measure of population health status. We can have an age-adjusted death rate. They're a better indicator than an unadjusted crude death rate for examining changes in the risk of death over a period of time when the age distribution is changing. Morbidity and mortality rates vary greatly depending on age, sex, race, and ethnicity. And 21st century mortality statistics show a shift in the leading causes of death. So again, we talked about that in chapter 1. The leading causes of death were communicable and somewhat preventable, and now we're seeing more lifestyle diseases that occur over us living longer. Life expectancy is the average number of years a person from a specific cohort is projected to live from a given point in time. So that cohort can be based on race, gender, culture, location, etc. So we can look at the life expectancy chart here, which shows from 1900 to 2013. For both sexes, the average life expectancy in the year 1900 was just over 47 years at birth. If you were a male, you were expected to live about 46. If you were a female, you were expected to live about 48. The most recent data on this table is from 2013, where both sexes' average life expectancy was 78.8, with males expected to live 76.4 years at birth and females to live 81.2. Now we can also look at the life expectancy at 65 years. So if you've made it to the 65 years of old or 65 years of age, how much longer are you expected to live? In 2013, you were expected to live another 19.3 years on average. That's another 17.9 years for males and 20.5 years for females. And then in 1980, because people started living longer, they started creating life expectancy charts at 75 years. So again, in 2013, if you were a male, you were expected to live another 11.2 years on average, and a female 12.9. Now that doesn't mean those years were guaranteed. Obviously, somebody could die the day after they turned 75. But on average, the people who lived to 75 lived an additional 12 years. Another important standardized measurement of health status of populations is years of potential life loss, abbreviated YPLL. The years of potential life lost are the number of years lost when death occurs before one's life expectancy. So in order to calculate YPLL, you need to know what the life expectancy is for that person. In order to calculate YPLL, you subtract the person's age at death from his or her life expectancy. This is difficult to determine because life expectancy changes at different ages. So for example, your life expectancy is different at 75. If you lived to be 75, you're expected to live on average another 12 years. But at birth, maybe your life expectancy is 80 years. So they often use the age 75 for calculations. The important thing to understand of YPLL is that it weighs the death of a young person as counting more than the death of an old person. Essentially, if you die at 30 and your life expectancy was 80, that's 50 years of life lost, versus if you die at 75 and you were expected to live till 80, that's 5 years of potential life lost. Other measures that you should note are the disability adjusted life years, or DALYs. They measure the burden of disease. 1 daily equals 1 lost year of healthy life. So it's a measure for the burden of disease that takes into account premature death and loss of healthy life resulting from a disability. Another important measure is the health adjusted life expectancy, which is the number of years of healthy life expected on average in a given population or region of the world. Let's now shift from standardized measures of the health of the status of a population to sources of secondary data. So secondary data is data collected by someone else, possibly for another purpose. They usually have specific value and usefulness to those in public health, and they're useful in planning of public health programs and facilities. So examples of secondary sources of data. The US Census is one, and whether you know it or not, you've been counted in a US Census. If you filled out the US Census report yourself, you were counted that way, but most often the head of household fills out the US Census data. It's taken every 10 years. It's basically a counting of the population, and it gathers data on race, age, income, employment, education, what kind of housing you have, and some other specific information. Now, the US Census data is an example of secondary data because it began in 1970 for appointing representation to the House of Representatives. Obviously, we can now use that data in order to plan, for example, health programs and facilities, understanding how many people live in a given location. Another source of secondary data is the Vital Statistics Report. So vital statistics are statistical summaries of records of major life events such as births, deaths, marriages, divorces, and infant deaths. It's published by the National Center for Health Statistics, which is under the CDC, and it calculates death rates by race and age. Additional sources of secondary data include the Morbidity and Mortality Weekly Report, the MMWR. And you can think back to the scheme of how we report disease and mortality. It's prepared by the CDC from the state health department reports, and it reports morbidity and mortality data by state and region of the US. It also reports outbreaks of disease, environmental hazards, unusual cases, or other public health problems. National health surveys are another form of secondary data. The National Health Interview Survey is a self-reported responses to questions about personal health. The National Health and Nutrition Examination Survey assesses the health and nutritional status of the general US population, and it uses a mobile examination center. The Behavioral Risk Factor Surveillance System is a state-based telephone survey of adults about high-risk behavior. Youth Risk Behavior Surveillance System is the national school-based survey monitoring 6 categories of priority health risk behaviors among youth and young adults. And National Healthcare Surveys comprises 11 different national surveys that gather information on the nation's healthcare system. The National Health Survey Act of 1956 authorized continuing survey of amount, distribution, and effects of illness and disability in the US. So again, there are 3 types of surveys: health interviews of people, clinical tests, measurements, and physical examination, and surveys of places where people receive medical care. Epidemiological studies are investigations that are carried out when disease or death occurs in unexpected or unacceptable numbers. These include both descriptive studies, which describe epidemics with respect to person, place, and time, and analytic studies, which are aimed at testing hypotheses. And you can think back to chapter 1 when we talked about an hypotheses and how we prove that. First, let's talk about descriptive studies. So descriptive studies describe epidemics with respect to person, place, and time. So who? We're thinking about case count, followed by who is ill. Are they children, men, women? What's their race, etc.? When? The times of onset for each case. And then we create an epidemic curve. You've seen those, and you heard maybe the term throughout the COVID pandemic, flatten the curve, right? We wanted to distribute the number of cases that occurred over time so that our healthcare systems didn't become overwhelmed. And then finally, where? Determine residential address and travel history so that in the case of communicable diseases, they can be stopped or slowed. The common source of an epidemic curve, each case can be traced to the same source. An incubation period is the period between exposure to a disease and the onset of symptoms. So in the case of COVID, we know that there's an incubation period of 7 to 10 days when somebody has exposure to disease and then starts to show symptoms. Point source, the exposure occurs at a single point in time. Continuous source, exposure is continuous or intermittent. And a propagated epidemic curve is when primary cases appear after incubation period, secondary cases appear after second incubation period, and they represent exposure to primary cases. So these epidemic curves graphically display the cases of disease according to the time or date of onset of symptoms. They're single epidemic curves. So again, these are used to calculate the incubation period of time between exposure to an infectious agent and onset of symptoms. And again, we have our point source epidemic curve and our continuous source epidemic curve. I'm going to give the definitions for those one more time. Our point source epidemic curve tracks the exposure that occurs at a single point in time, and our continuous source epidemic curve tracks the exposure that's continuous or intermittent. The propagated epidemic curve, again, primary cases appear after incubation period, secondary cases appear after second incubation period, and represent exposure to primary cases. So our first type of epidemiological studies are descriptive studies. The second type are analytic studies. Analytic studies are aimed at testing hypotheses, and these are about relationships between health problems and possible risk factors. So risk factors, again, are factors that increase the probability of disease, injury, or death. An observational study is an analytic epidemiological study in which the investigator observes the natural course of events, noting exposed and unexposed subjects and disease development. Experimental studies are different in that they're an analytic study in which the investigator allocates exposure or intervention and follows development of disease. So in an experimental study, the investigator is providing exposure. Usually a placebo is also offered. So you have two test groups, a control group and a group that's receiving treatment or exposure. And then they follow the development of the disease to track how many people actually come down with the illness, how many people get symptoms, and how many people remain healthy. Experimental studies are carried out to identify cause of disease or determine effectiveness of vaccine, drug, or procedure. And again, the placebo is a blank treatment. So you need to know that the exposure or the vaccine or the drug is actually having an effect. And in order to do that, you have to give part of the population, part of the test group, a placebo in order to have something to compare to. So the last concept that we're going to talk about is causation. So causation questions the exposure causing development of disease. You're looking at the development and cause of disease and asking the question, did risk cause disease? So criteria to be considered when deciding whether an association might be one of causation is the strength, the consistency, the specificity, temporality, and biological plausibility. These things have to be met in order for causation to be determined. Some questions for you to consider before you move forward. How can data collection for notifiable diseases be improved? Why is tracking vital statistics so important? And how does calculating years of potential life loss change the way we think about community health efforts? That's the end of the Chapter 3 lecture. Have a great week.